Hi, I'm Dr. Seth Martin. I'm a professor of medicine at Johns Hopkins. I'm a cardiologist and a lipid specialist, and excited to join you today. Let's get right to your questions. Yeah, this is a great question around the causes of cholesterol. Certainly, diet and genetics are key contributors, and it's a mix of those two factors in people in terms of which is really driving things. Certainly, in the case of familial hypercholesterolemia, genetics can be it plays a key role from birth. But what else can drive total cholesterol into the 300s? There are some other things to consider. First, physical activity. So lack of physical activity can elevate cholesterol. So opportunities to modify our physical activity levels, getting the most total amount of physical activity in terms of steps per day. A step goal of 8,000 or 10,000 steps per day is a common goal, as well as the aerobic activity sessions and resistance exercises. So physical activity can help with controlling cholesterol, with controlling LDL, with controlling the atherogenic lipoproteins. But it's good for our health in general, for cardiovascular health, for prevention of cancer, for mental health. So looking at physical activity and exercise is really another key area to look. And then other conditions can raise cholesterol. So hypothyroidism is a condition that can raise cholesterol levels. That's why we commonly test thyroid levels in outpatient clinics. We also commonly test for markers of kidney function and liver function, because kidney disease and liver disease also can be linked to elevations in cholesterol levels or LDL levels or apolipoprotein B levels. One rare condition that is very interesting that comes up though from time to time related to liver disease that could lead to large elevations is a condition called lipoprotein X. This can happen in liver diseases where the bile is not flowing properly, conditions such as primary biliary cirrhosis. When the bile flow is impeded, the liver can produce this, what's called lipoprotein X, and it's interpreted by the labs as high LDL levels, high total cholesterol levels. So these patients can even present with a lipid profile that looks similar to a patient with homozygous FH, so very high LDL and total cholesterol levels, but it's actually due to the underlying liver disease and the problem with bile flow. What's interesting is that these LPX particles don't have ApoB attached to them. So one of the ways of making the diagnosis is also checking an apolipoprotein B, which will be discordantly low. So those are just some of the other causes to consider for someone that has a very high total cholesterol level. When it comes to screening in children, generally speaking, we want to start as early as possible. There's some differences in recommendations out there between different professional societies, professional bodies. But let's start with families who have known familial hypercholesterolemia or have known early atherosclerotic cardiovascular disease. There's pretty broad consensus that we should be starting as early as age 2. So that is very important in making the early diagnosis, because children then can be coached around their lifestyle habits, but also there can be early institution of lipid lowering therapy. So as early as age 2 for cholesterol testing or cholesterol screening in children who are at higher risk. Now, when it comes to children that fall outside of those higher risk groups, the American Academy of Pediatrics does endorse starting cholesterol testing around age 9. So even in those younger individuals, it's important to do this. And frankly, this doesn't happen as routinely in clinical practice as we should. So I think this is a message that we want to get out there more and more, that if there's certain risk factors like the family history of familial hypercholesterolemia or cardiovascular disease, to start at age 2, but at a minimum start around age 9. So PCSK9 inhibitors and other novel therapies, we're very fortunate now to have the therapies that we have, a really effective group of therapies. Generally, the new therapies have been studied in addition to statin therapy. Some patients who have not been able to take statin therapy will take them instead of statin therapy, but generally speaking, the best therapy is to be taking these new therapies in combination with statin therapy to achieve the lowest LDL and ApoB results. So in terms of the LDL lowering efficacy, how well these drugs work, PCSK9 inhibitors can lower LDL about 60% on average. Now, of course, it does depend on the person. Some patients with familial hypercholesterolemia will have less response than that, but the average response with PCSK9 inhibitors can be about 60%, whereas the most effective statins can be about 50 to 55%. So they're really in the same ballpark in terms of the amount of LDL lowering, but the two work best together. So generally, the message I want to give is that combination therapy is really key when it comes to treating familial hypercholesterolemia, because when we're starting at really high LDL levels, it takes combination therapy typically to get down to optimal LDL. So I wouldn't say that they're necessarily more effective than traditional statins, but they're a great option to be added to statins, and in certain cases be used instead of statins. Yeah, why would one child get FH and the sibling not get it? That is what we would expect, about a 50% probability of inheriting FH in a child from a parent, if one parent has FH. So FH is usually inherited as an autosomal dominant condition. So there are other inheritance patterns that are more rare, but the typical inheritance pattern is autosomal dominant. And so that means that if one parent has heterozygous FH, meaning that one parent has a gene variant, gene mutation causing FH, then there's 50% chance they'll pass along that copy of the mutated gene versus passing on the normal gene. So in each child, there's that 50% chance. And so if those chances play out the way that you may expect, then one child would get it and one would not. But it is also possible that both children could get it, or both could not get it. So it really is a play of chance, but there is that 50% possibility when there's one mutated gene that's being passed along. So the short answer, it's not required, but it can be helpful. We do offer genetic testing to all of the patients in our clinic, but not everyone does it. And we recognize that our clinic is very lucky to have an amazing genetic counselor, Emily Brown, who's been involved with the Family Heart Foundation as well as the NLA, understanding how to use genetic testing best to diagnose FH and other genetic lipid disorders. But not every clinic necessarily has those resources. It's not always as easy. So there are, you can make a clinical diagnosis based on the LDL level, the family history of high cholesterol and cardiovascular disease, the patient's personal history of cardiovascular disease, as well as using physical exam findings. And there's different clinical scoring systems out there. The American Heart Association has criteria. There's the Dutch Lipid Clinic criteria. We find those clinically useful, and a clinical diagnosis of FH can be made. But the genetic testing can help to confirm the diagnosis. And it's often that patients will have clinical criteria that suggest possible or probable familial hypercholesterolemia, and genetic testing could help understand that it's really definite familial hypercholesterolemia. The genetic testing also, if you identify the mutated gene, that then can be used for family members, really, and for all future generations of the family to help facilitate early diagnosis. So it can be useful in identifying those at-risk family members. And then there's certain cases where the LDL levels might be really in a gray zone. For example, in maybe just to give a specific example, I've seen like younger people who are very kind of athletic and following a healthy diet. Their LDL level seems higher than you'd expect based on how the type of lifestyle they're leading. And they're below kind of the typical thresholds that we use for LDL. Their genetic testing could clarify the diagnosis in that uncertain case that doesn't meet kind of the textbook criteria. So in short, genetic testing's not required, but it can be helpful in diagnosing FH. So it's generally a low percentage, a single-digit percentage. We have some experience. I mentioned we've been fortunate to have Emily Brown as our genetic counselor, and she did lead a paper from our clinic experience looking at individuals who tested negative for the traditional FH-causing gene mutations and then had an extended panel. We found that the yield was 0.7% in our experience. In other research, it may be a bit higher, but I think it isn't a single-digit percentage in terms of how many patients we should expect to test positive for these additional genes. Not to say that it's because of that lower yield that it's not valuable. Certainly in the people that find those gene mutations, it can be quite clarifying. But I think the expectations are on the lower side in terms of how many people will find it. So if we go into that genetic testing, I think it's important to do so kind of, not being disappointed if we don't find a gene mutation, because it's really, in all probability, we won't find it, but sometimes we will. This is absolutely true. The lower, the better is the short answer. So as we get to LDL levels below 70, that what the studies have shown is that we tend to start seeing some reversal. But as we go down to lower and lower levels, even down to LDL levels below 20, there's more reversal. One of the best studies that has been published in this area was one of the PCSK9 trials, the Fourier trial. Before that large outcomes trial, there was the Glagoff trial, which looked at plaque using intravascular ultrasound over a couple of years based on adding PCSK9 inhibitors to background statin therapy. And what was found is the lower LDL went, the better in terms of plaque regression. So this also fits with the clinical outcome trials that have shown that the lower we go, the more we prevent cardiovascular events, including heart attacks and strokes. So this has led to the current thinking: the lower the LDL, the better. And the plaque regression is something that happens over years. And so the studies like Glagoff that I mentioned have been a relatively short amount a short snapshot of someone's life, a couple of years. So if we imagine that type of process happening over decades, it really is encouraging how much we may be able to reverse atherosclerosis, at a minimum, halt the process of atherosclerosis, but even reverse atherosclerosis and stabilize plaque. So that's what some of the other research has shown, that it can also lead to favorable changes in plaque characteristics that make them less likely to cause problems. So getting the LDL levels down and generally getting LDL below 70 would correlate with getting apolipoprotein B levels down to 60. The average ApoB levels in some of the clinical trials using PCSK9 inhibitors are getting ApoB down to 30s, 40s kind of range, and getting LDL in the Fourier trial got down to an average LDL of 30. But what was found is getting to LDL levels less than 20 was even better and totally safe. So it's a really exciting time to have such effective therapies that can drive levels down really low, reverse atherosclerosis, prevent events, and for us to be able to do it in a manner that's very safe. Several, and we've been very lucky to have all the research and innovation that has led us to have the therapies that we had today. We've talked about statins and PCSK9 inhibitors. We also have ezetimibe, bempedoic acid. We have evanicumab. We of course have apheresis. And I'm probably, those are LDL lowering therapies, not to mention triglyceride lowering therapies and so forth. So we've been very fortunate to have the available therapies that we have, but still some people could benefit from having other options. One option that's in the pipeline is called obicetrapib. It's an oral CETP inhibitor. It can robustly lower LDL, and there's multiple clinical trials of obicetrapib happening right now. It's very interesting because this class of drugs, CETP inhibitors, was originally focused on HDL cholesterol raising, and that didn't pan out. But obicetrapib is notable for its ability to lower LDL, and that's the way that it's been developed and tested in the trials. So that's one to keep on a lookout for, because it's another very effective oral drug that hopefully will make it to the finish line into clinical practice. And then along the lines of oral therapy, there's oral PCSK9 inhibition that's on the horizon. We already, of course, have PCSK9 inhibitors in the form of monoclonal antibody therapy, including evolocumab and alirocumab, and then we have inclisiran as an siRNA therapy. So that's a class that's already, well established in clinical practice. But if this development program pans out, there could be an oral option for PCSK9 inhibition. So that's another thing to look out for. And then also kind of in the near term, we have LPA-directed treatment, and the Family Heart Foundation, of course, provides a lot of fantastic education and advocacy around LPA, in addition to familial hypercholesterolemia. And so there's multiple clinical outcome trials looking at the effect of therapies to lower cardiovascular events, including heart attacks and strokes. And so we're very hopeful that those are going to pan out. There's strong evidence that LPA is causal of atherosclerotic cardiovascular disease as well as aortic valve disease. And these therapies that are being tested robustly lower LPA, more than 80-90%, dropping the levels. And LPA is strongly inherited, with its levels being primarily determined by genes. So we're very hopeful these trials are going to show positive results and that those drugs will make their way into clinical practice. And that's we're going to be getting the readouts from those trials in the next couple of years. And then in the more distant future is gene editing therapy looks very promising. There are multiple companies working on therapies that can modify the genes, such as PCSK9, to convert somebody to looking like someone who was born with that type of favorable knockout mutation in PCSK9. So the really innovative aspect of that is that it would be a durable effect, expected to last lifelong, where you get one injection, one treatment, or some initial series of treatments. But then after that initial dosing, that you would then have a durable effect lasting over the long term. So whenever it comes to gene editing technologies, of course, that's there's a number of kind of safety hoops to jump through. A lot of work has to go into bringing that type of technology to clinical practice. So that's going to take a number of years to work through. But that is something that's a real possibility to come to practice to treat LDL levels. Thank you so much. It was really an honor and privilege to participate with you today. Thank you to everyone for your questions. They were really impressive and sophisticated, and I enjoyed answering them. I would encourage you to continue the learning at familyheart.org. And if you have specific needs related to your healthcare journey, you can contact the Family Heart Foundation Care Navigator.